it is insanity. I always go back to Einstein, right? The definition of insanity is trying the same thing again and expecting different results. We've run the experiment has failed, right? And as a heart surgeon, as a doctor, right, I can no longer accept that the results of what we were trying are so disastrous. We have to change course. And, in some ways that's working to our benefit, because the simple truth is we as a society, right, can no longer support the disastrous results we're getting from our previous nutrition.
We're bringing healthy back. Them other bros don't know about the facts.
All right. Hello, everybody. Welcome back to the Magic of Metabolic Health podcast, episode 22, where optimized metabolic health is our goal, and we are here to get you there. My name is Amelia Wood, and I am a food first personal trainer and metabolic health coach. And today we have Dr. Fumi in the studio. Hey, Fumi.
Hi, guys. My name is Dr. Fumi Aoyami, metabolic health internal medicine specialist.
And of course, our lovely guest, Dr. Philip Ovadia. Hello.
Great to be here with you, Amelia and Dr. Fumi. Really looking forward to a great conversation with you and your audience.
Yes. Now, before we get into all the good stuff, we just want to remind our listeners that here at the Magic of Metabolic Health podcast, we are building a village that encompasses every part of who you are. We release guilt and shame in the quest for perfection, and show you how self-efficacy and knowing your why are crucial tools in sustainable behavior change and optimizing your metabolic health.
That's right.
So let's get started with a little introduction about Dr. Philip Ovadia. In 2015, Dr. Ovadia adopted a low-carb way of eating and has effortlessly maintained a weight loss of nearly 100 pounds ever since. And since 2019, he has mostly followed a carnivorous diet. He has extensively researched the health benefits of low-carb diets with a focus on heart health. Conducting over 3,000 heart surgeries has taught Dr. Philip Ovadia that good health comes from lifestyle and nutrition, not from surgery. Sadly, many of his patients considered their heart attacks inevitable. He is now on a mission to help people stay off his operating table by giving them the tools and mindset to never need a heart surgeon. Welcome, Dr. Ovadia.
Yeah,
Thank you.
Yeah, so let's just jump right into it. You are a cardiologist and you are a heart surgeon. That's something that I have been dying to talk about on our show, because it seems like heart health is one of people's biggest concerns, but also biggest confusions, right?
Sure.
So I think part of the reason why we're so confused is how we grew up, right? What we were taught, whether it was indirectly or directly from our families, our culture, from school, from the movies, right? So we always ask our guests this first question. If you could share where you grew up and what kind of food you ate as a child, what were the values that your family had around food, what kind of food, and then we'll get into sort of how that shaped you later in life.
Yeah, so I grew up in New York on Long Island. What I would say was a very typical suburban family. And, I was born in 1974 and the food pyramid hit in 1980. And my parents both struggled with obesity throughout their life. And I also, my older brother, when he was about 8 and I was about 5, was diagnosed with type 1 diabetes. So that led us very much into, we had no sugar in the house. We were, a low sugar household. And I would say we ate largely in line with the dietary guidelines. I distinctly remember, from that early age, right, my brother doing the calculations, right? Of, there's this many carbs in the meal, because all meals had to have their carbs, right? The base of the pyramid. And this is how much insulin I need to take to cover that amount of carbs. And and we had margarine instead of butter. We had skim milk. We had all the healthy cereals, the Wheaties, the Cheerios, and I'll put healthy in parentheses.
Big
And,
time.
we had our skim milk with it. We were a lot of chicken and, occasional red meat and, some fish. And I think back to the way I was raised, and I would say it was very much in line with the dietary guidelines. And as I said, both my parents struggled with obesity. I struggled with obesity from, probably, pre-teens, 10, 11 years old and onwards. Really my whole family went through that same struggle despite following the guidelines. And it was, you have to fast forward 30 years, right, to when I'm 15 years into my career as a heart surgeon, and I am morbidly obese. I am pre-diabetic. And I came to this realization that I was going to end up on my own operating table, so to speak.
Wow.
I was going down that same path that, all my patients, essentially went down. And like so many of them, I realized I didn't know what to do about it. All this advice that I had been taught in school that I think I did a pretty decent job of following. I'm not going to say I was perfect. No one is, but I think I did a pretty good job of, low fat, food pyramid. I remember, multiple times throughout college and medical school, right, that I said, okay, I'm going to count my calories. I'm going to, go exercise more. And, I'd lose some weight and then I would gain it back and I'd gain back more. And, it finally, again, came to I kind of came to that realization that this wasn't working. And thankfully, about that same time, as you mentioned in my bio, 2015, I stumbled across low carb diets. Ironically enough, I stumbled across it at the Society of Thoracic Surgeons. So this is the largest annual meeting of heart surgeons.
Wow.
And there happened to be a guest speaker that year by the name of Gary Taubes. And he had just written the book, The Case Against Sugar. And of course, before that, he had written, Good Calories, Bad Calories, and Why We Get Fat. And, when Gary was talking about, it's not how much food you eat, it's the type of food that you eat that determines whether or not you're going to end up overweight and fat. And I was like, never heard this before. Right? All of that medical school stuff, 10 years as a cardiac surgeon, no one ever mentioned, low carb, high fat, right? It sounded like heresy. But at that point, I was like, well, nothing else has worked. Let me give it a try. And that's what really started me down the path that, we're at today, where low carb worked great for me. Started, some friends, some family, they did it, saw great results. It led me to start asking some different questions about heart disease, the disease that I had dedicated my career to fighting against. And now, here I am, as you said, trying to keep people off the operating table and realizing that metabolic health is the way to do that.
This is a lot to take in, as in you started off with a family that, two parents that were obese. You had the young diagnosis of type 1 diabetes. You've had all the medical training, and then you had your own personal come to Jesus moment within the field of medicine, as in, how do you feel now that the new guidelines for healthy diets and the new food pyramid has come out just recently within the last month? How do you feel now that all of this has suddenly been reversed?
I mean, it's amazing to see it coming more into the conversation, right? We have a long way to go. The unfortunate thing is, right, if I go around the hospital and ask my colleagues what they think of the new food guidelines, I'm going to guess that 70, 80, maybe 90% of them are going to say, oh, those are crazy. No one should follow them. It's all political, whatever they're going to say, right? But, I say, great, this is what I've been talking about for the past decade. This is what I've now seen so many patients benefit from. This is what I've benefited from personally. And, I'm glad to see it's finally entering the conversation. And, I don't get quite as crazy a look when I'm sitting in the doctor's lounge in the morning eating a, plate full of bacon and eggs, right, as I used to as the heart surgeon. And, of course, right, that was just insane. Here's the heart surgeon eating bacon and eggs for breakfast. What's going on here? But again, I'm no longer a morbidly obese pre-diabetic heart surgeon. I'm in better shape today than I was in high school. And that's in the context of basically doing the exact opposite what I had been taught in school.
I love that. And the reason I love that is because the results speak for itself. A lot of the time we have such a long history of propaganda concerning these diets and what is supposed to be healthy. Meanwhile, when people do these diets, whether it's low carb, carnivore, whatever the case may be, the results speak for themselves. Patients feel better, the biomarkers look better, you feel better. As clinically, if you feel better, if I have a patient that feels better and then their labs are going in the opposite way, I typically go for what clinically looks better because that is what we're seeing in our real life. Do you feel the same?
We have this very strange situation, I'll call it charitably, right? Because not only do the patients feel better, right? But when we look at the blood work, the vast majority of it actually looks better. But there's one number that, the perception is that number got worse. Their cholesterol, their LDL cholesterol specifically, ApoB, if you want to be fancier talking about it, right?
Oh, yeah.
That number goes in what everyone perceives to be the wrong direction. And in most doctors' mind, that completely invalidates this approach. And I've literally had patients told by their doctors, your diabetes went away, you're off your blood pressure medication, but your LDL cholesterol went up. This diet is killing you. You need to stop. And quite frankly, at this point, I consider it to be malpractice. I consider it to be uninformed, and it's just, it just doesn't make any sense, right? How could it be that all this stuff in our body gets better, and somehow the same diet, the same intervention is harming the heart while everything else is getting better? It just makes no sense. Of course, I spend a lot of my time discussing this with patients, trying to have these conversations with my colleagues, and trying to get this information out there that what we just all have been led to believe, it's just not true. Dr. Fumi, you probably remember in medical school, right? They probably told you some version of, by the time you retire, half of what you learned in school is going to be proven to be wrong.
100%.
Yeah, it's a common saying. We all hear it during school, but yet we get out into practice and we forget it, right? No one can think, oh, wait, maybe this is one of the things that, is being proven wrong. But the cholesterol hypothesis, the cholesterol myth, I call it at this point, is so well ingrained within our medical system. And we can go into all of the different aspects of it, the influence of the pharmaceutical companies, it's just what one of the central truths that our system has been built around. And quite frankly, it's too much for the average doctor to consider it might be wrong, right? This is one of the fundamental truths that we were never supposed to question. And yet there's many, many reasons to question it. And, admittedly, it's not easy to do that, right? It wasn't easy for me to basically say the way I approached this disease for the first half of my career was wrong. The advice that I was giving patients was wrong, and may have caused harm. And again, I didn't know it, right? But, that's what many doctors face. And quite frankly, many doctors just aren't equipped to even consider that.
It's a hard conversation to have because the hill is so big. We would have to then essentially scale back our use of statins in patients that have less risk factors, patients that don't have cardiovascular risk, patients that don't have cardiovascular disease. We would essentially have to almost all doctors, or at least a small fraction, 25% of doctors that come together and have a study, a progressive study, something that shows that cholesterol is not the target, that perhaps sugar is the target, or insulin resistance is the target. We need if you're going to do a coup, any coup in the medical industry or in history, you need the fall guy. And if we're saying it's not cholesterol, we need to be able to have a target to say it's this guy. And we're already saying that it's sugar. We're saying it's sugar in so many ways by saying low carb diets work, ketogenic diets work, carnivore diets work, but unless you're ready to stand in front of the sugar lobby and say this is the one, this is the person we have to take down, it's going to be a tough one. It's a tough one to sell. I remember in residency I was completely keto, and of course I was looked at just as crazy, eating sausage and eggs every single morning and drinking my water and taking my magnesium, but I had more energy than any single person in my residency. I was able to do so much more with that, and I continue to keep that in my practice today. But of course, I'm only one doctor. It has to be more of us. It has to be more of us on this trend, more of us having these podcasts, having these conversations, going to these conferences, letting the word be out and saying it out loud in broad daylight and not in secret. It's like, hey, this is what's really going on. And we need people who's going to be at the forefront of this to be able to say, this is the right thing to do, not just for like the sugar or the cholesterol, but for like humanity, for all of us. Otherwise, what are we doing? Like, we're just talking amongst ourselves inside the conferences. I love going to the conferences and talking about that what we know about cholesterol and what we know about mitochondrial health, but how do we get it out to the people? How do we get it out into the hospitals, into the general practitioners in the rural areas? How do we make this like a commonplace thing? That's my issue right now, quite frankly.
And I think the best approach to that today is we get the word out to the patients, right? I think ultimately this isn't going to be some top down. I am never expecting the American Heart Association to come out and say, you know what, we were wrong about that whole cholesterol thing. The way that I think this is all going to change, and quite frankly, what we're starting to see is when enough people are talking about it, when they're demanding it, when they're going to their doctors and saying, why don't you talk to me about this? Why have you never tested my insulin level? Why haven't you told me I'm insulin resistant? And that is what is, the major risk factor for heart disease. The more patients take that to their doctors, they're going to start waking up to that. Now again, like we talked about earlier, thankfully we are starting to see some stuff come from the top down. We now have new food guidelines that emphasize eat real food, right? I could not be happier that the website that is now the nutritional guidelines, right? It is realfood.gov. Couldn't be any simpler. I think the messaging is simple. I think it's great. Huge step that we're taking. I think over time, right, we're starting to see this shift. One of the, I think, things that becomes most important in this conversation is, we have to start being honest about, okay, we thought it was fat. We recommended low fat. We came up with statins. We came up with all the other medications that lower cholesterol. What has happened to heart disease during that time? Heart disease is still far and away the number one killer. It has not gotten any better. So if after 40 years of trying this, right, it's not getting any better, I just can no longer tolerate the people that say, well, it's because people aren't listening. Well, it's because we didn't lower the cholesterol enough. Let's lower the guidelines another time. Let's start earlier, right? We literally have people out there, guidelines now out there saying we should be testing teenagers and we should be starting them on cholesterol lowering medication. It is insanity. I always go back to Einstein, right? The definition of insanity is trying the same thing again and expecting different results. We've run the experiment has failed, right? And as a heart surgeon, as a doctor, right, I can no longer accept that the results of what we were trying are so disastrous. We have to change course. And, in some ways that's working to our benefit, because the simple truth is we as a society, right, can no longer support the disastrous results we're getting from our previous nutritional.
Sure. Understandable. I am 100% on board with doing. If you want a result that you've never had, you have to do something you've never done. And what we've done is not working. And so if we have to scrap the whole thing and try something else completely, I I am results driven. Whatever brings about that result, I'm willing to do. And that's why it was so easy for me to do a ketogenic diet for 10 years, because guess what? The results speak for itself. And so when I have patients that they're sick, they're tired, they're fed up, and they're willing to do anything, because that's what they say in the clinics. And they say in the inpatient, doc, I've done everything. I do it to a T. I'm sick, I'm tired, I am ready to give up. What else can I do? I say, hey, there's this thing, as in, there's lots of studies on it, but it's not mainstream. If you want to try, you can do it. And if you like it, we'll keep doing it. And no matter any type of patient I have, no matter from any walk of life, from any culture, from gender, background, socioeconomic status, it works across the board. So if something like this works across the board, even anecdotally, then why not try it? Especially considering that the more numbers that we have of people doing this, the more that we're seeing so many results. Why not? Is my real standpoint in all of this. Why not?
In my mind, the biggest barrier for most doctors is because it means admitting that what you did before wasn't the right advice, right? And we as doctors, that's a very hard thing for us to accept, that we made a mistake. Now, again, I don't blame other doctors, right? We know what the system is. We know how we got educated. We know what all the guidelines say, right? The quality metrics, they're all built around this same thing. But ultimately, I look my colleagues in the eyes and I say, how's it working out? How are your patients doing? Are they getting better?
That's right.
And, I think that's kind of the most jarring question that we can ask, right? And we're in this environment where, doctors, all healthcare professionals, this doesn't just apply to doctors, but, we're seeing all the burnout, right? All the fatigue, all the, doctors and other professionals that are just quitting, right? Because they just can't do it anymore. Mm-hmm. And the real reality, right? We talk about, it's because of the burdensome regulations and we have to deal with the medical records and the EMR and billing and all of this. But the real reality in my mind comes down to when doctors are seeing their patients getting worse. That is the most demoralizing thing to a doctor, and no doctor wants that. And unfortunately, that's what they're up against, right? And, yes, even someone like myself, right? Okay, I do heart surgery, it's successful, great, right? But, when I really now look at it, right? Okay, I was successful, but the patient still died of heart disease. They died a decade later. They had, better quality of life during that time. So I recognize the value in that. But, I'm not really fixing the problem for them. I'm putting a Band-Aid on it. And, the internists out there, right, that are just seeing this endless supply of sicker and sicker patients coming through their doors, of course they're going to get demoralized. And we need to really start talking about that central issue. That's how we're going to get doctors to get on board with, did you know that we can reverse 60% of type 2 diabetes after 2 years on a low-carb diet? Here's the published data. You've never seen that study? Because it got buried in some second-rate journal when it should have been on the front page of, JAMA and the New York Times, right? Because it is monumentally successful data. And, that's what we have to start getting out to doctors.
Mm.
one of my questions as you're talking is if you just do a surgery, right? And maybe you're doing a follow-up with your patient, whether it's a week, 2 weeks, a month later, do you bring this up? I mean, do you say, okay, now that we unclogged this artery or whatever, do you want to know how to keep it clear naturally as possible? I mean, how do you have those conversations and what are they like? Because I know several people, many people who've had heart surgery, and the first thing they're told is high fiber, low fat every time. Stay away from red meat, stay away from saturated fat, and it doesn't work. So how do you actually approach that, like with your patients?
So I don't wait till after the surgery. I have this
Mm.
conversation beforehand with them, and I tell them, listen, your blood vessels are blocked. We need to deal with that, but we need to deal with why your blood vessels became blocked. Because if we don't, you're going to have, you know, ongoing problems related to this, right? The surgery doesn't correct why you got the problem in the first place. You're going to feel better. We're going to extend your life. We might be saving your life, right? If you're in the midst of having a heart attack when we do the surgery, but we need to address why the blood vessels got blocked in the first place. And, I kind of lay it out. What you've heard your whole life, unfortunately, we were giving the wrong advice. This is what I now know. This is what I experienced personally. A lot of times I'll hand them a copy of my first book, Stay Off My Operating Table. I say, you're going to be in the hospital for 5 days. You got a chance to read this. Oh, by the way, unfortunately, the majority of the food that they're going to put in front of you over the next 5 days, pretty much you don't want to eat it, but
Oh my goodness.
we do ease into it a little bit, and the reception is generally great. Like because the number one question that patients oftentimes are asking me, right, when we're having that conversation, they're like, "Why did this happen? I've been on the low fat diet. I've been taking the medications. Why am I here?" Right. And so it does lead into that conversation. And, I feel that I am much better prepared, right, as a surgeon now because I can have that conversation. I am bringing that holistic care. Now, unfortunately, right, like I said, earlier, that patient then comes back a month later, right, for their post-op visit. And they're like, oh, I did what you said. I went home, I started eating low carb, I was losing some weight, I was feeling great. And then I went to my cardiologist and they told me, you can't do that. You can't eat high fat, like you're doing. You can't eat red meat, it gets into this conflict. And in the surgical side of my career, I don't have that long-term ongoing relationship with the patient. I try and support them the best I can. Fortunately, I have a second part of my practice. I have an online nationwide telemedicine practice. I've become licensed in all 50 states. And that's where I can see the patients. And, that's where we have the ongoing relationship. And I have a fabulous team with a nurse practitioner, with health coaches, right? And we can do that, real longer term holistic care, doing all the testing. And we're seeing great success over there. And, more and more I shift towards doing that. And I find myself doing less and less of the surgery because, quite frankly, I see myself having a greater impact over there. And then coming on podcasts like this and, getting, books out, my second book coming out soon, YouTube, all of that stuff, right? These are amazing tools for us to have these days. And I am very excited about where that continues to lead to.
That's wonderful. I love that.
So your next book, since we're talking about it, I would love for you to share why you wrote this second book and how it's related to your first book for those who don't know.
Yeah, thank you. So the second book is called Stay Off My Kitchen Table. and it is available for pre-order now, being released in July. And, it goes a little bit more into the why, where the first book was really focused on the how. How do you stay off my operating table? And stay off my kitchen table is a little bit more about why those recommendations, work. We talk about things like nutrient density. We talk about bioavailability. We talk about gut health, and we talk about how that leads us to, low carb, ketogenic, carnivore diets being the best thing for our overall health.
That's great. It's a
I need to get a
very,
copy of this.
yeah, it's a catchy title. And I saw your face, Fumi. You're like,
No, because it riffs
them.
off the first book. So I actually love it. I love the continuity of it. I am really looking forward to this next book. Well, and you said I can get a copy now?
Pre-order now, coming out in July. But yes, it's
Dr.
available.
Oveda, give me a signed copy. I want one directly from you. What are we talking about here?
Yes, indeed. We will get that for you.
Okay,
Yes.
so I want to jump back a little bit into the conversation we were having about what we've been taught wrong with very good intentions for decades and decades. And so if some of your patients might be listening or watching, our crew, our village is really, I know, excited about this conversation, because one of the questions I keep hearing from people is, so my doctor says I have high cholesterol, but I don't understand it. Because, for example, I'll ask my clients or friends, they'll come to me and be like, yeah, I got high cholesterol. And I'll say, which one? Which one's high? And they say, oh, I don't know. My doctor just said I had high cholesterol. And I was like, every time I'm like, okay, all right, cool. So can you grab your test results and show me which ones were high? And of course, generally, the ones that are high are LDL and triglycerides. And I don't want to get too much down the rabbit hole. I just listened to your episode with Dave Feldman, and he did a great job explaining how fat is transported and carried and turned over and all that stuff. So for folks who want a really good description from an engineer, you can check out Dr. Ovadia's episode. Do you remember what number episode that was?
As we're recording this today, Dave Feldman coming on my podcast was just released. So the Stay Off My Operating Table podcast came out today, March 31st. I don't know the episode number. We're in like 270 something. And then about 2 weeks ago, I had gone on Dave's podcast, the Dave Feldman Protocol, and we had a nearly 4-hour conversation about all of this. So that really is a good one to direct people to. And you can find that on YouTube. And like I said, it came out a couple of weeks ago, beginning of March. But either one is a good one.
Dr. Vadia, did you say episode 277?
Stay off my operating table. I'm proud to say we're at somewhere in the 270s, I believe, on our episode.
Jeez. Amelia, isn't this episode 22? We've got a long way. We've got a long way ahead of us.
You got to have an episode 22 before you have 222, right? And 272.
You know what? I will take that. I will take that.
Yeah, I looked it up. Episode 243 that I was listening to today with Dave Feldman of The Cholesterol Code, the new film, the new documentary that I will be hosting a screening of here in Edmonds, Washington on April 20th. Super excited for that. And Dr. Sean Baker is going to attend and do a Q&A with us. Yeah. So anyway, back to that question. People are confused, right?
Yes. The answer is not all high cholesterol is the same. And, to take it back a step, what I always tell people is you got to understand the environment that cholesterol is in. So, to get real basic, right, you get your cholesterol panel checked. There's going to be 3 main numbers on there. You're going to have, or really 4 main numbers, right? So you're going to have your total cholesterol. You're going to have your LDL cholesterol. You're going to have your HDL cholesterol. and you're going to have your triglycerides. And just to keep it real simple, right? HDL cholesterol, you're going to hear your doctor call good cholesterol. LDL cholesterol, you're going to hear your doctor call bad cholesterol. But it turns out it's not that straightforward. And not all LDL is the same, and probably not all HDL is the same. And then you have this third other thing, triglycerides, which aren't actually cholesterol, but they're a different way of, fat is kind of moving through your bloodstream. I think just about everyone's in agreement that triglycerides are not good. Having more of them is not good. But we don't we don't contextualize that. The sad reality is when most doctors say your cholesterol is high, they are looking at your LDL cholesterol, and they are maybe looking at your total cholesterol, which is, mostly LDL cholesterol anyway, for the majority of people. And they are assuming that tells them everything they need to know about your risk for developing heart disease. But here's the problem. Half of the patients that come into the hospital with a heart attack, half of the patients that end up on my operating table for heart surgery, they do not have high LDL cholesterol levels. Some of them because they're on medication, some of them just because that's their natural, levels of cholesterol, and yet they still end up with heart disease. So it turns out that this is a very lousy predictor of whether or not you're going to get heart disease. We have much better predictors of whether or not you're going to get heart disease. Dr. Fumi talked earlier on, she said, well, if we only had the data around, insulin resistance causing heart disease. We do have the data. We've had it since the 1970s. Dr. Kraft did all of the work that we needed because Dr. Kraft looked at patients coming into his hospital with a heart attack, and he checked whether or not they had insulin resistance. And you know what? 95% of them did. If you test for insulin resistance correctly, right? So 95% versus 50%, which metric should we be paying more attention to? Of course, insulin resistance, the 95% one, but we don't because we don't have the magic pill to fix insulin resistance. We do have the magic pill to bring your LDL cholesterol level down, and that's the sole reason, right, why we focus so much on LDL cholesterol and we ignore the biggest risk factor, which is insulin resistance. So if your doctor tells you your cholesterol is high, yes, you should ask them, what are you talking about? Which cholesterol is high? What does that mean? And then your follow-up question should be, am I insulin resistant? Because it turns out that whether or not you're insulin resistant has a big impact on whether or not that high cholesterol is meaningful or not. And that's something that the medical system misses. And quite frankly, I believe that's the reason why we haven't made an impact on heart disease, because we've been distracted by the wrong numbers to be looking at. And while we, do things to fix the cholesterol, we ignore the fact that the vast majority of heart patients have insulin resistance that's not being addressed, and therefore the disease continues to get worse.
This is a powerful conversation. This is the highlight of my day because this is exactly the type of conversations that I want my patients to be having. Sometimes when you're going to the hospital, whether you're going in outpatient or you're going inpatient, it's hard to ask your doctor the right questions. And so when I prompt my patients to go talk to their primary care physician, because like I said, I work as an inpatient doctor. And so when I stabilize my patients and I send them back to their primaries, they say, what should I be asking my doctors? What tests should I be asking? How do I help myself? So I give them a protocol. I give them 5 questions that they should be asking their doctors. And I do believe that the chief amongst them should be, am I insulin resistant? Because once again, you'll have a normal lipid panel and you could very well have heart disease. And we see this all the time. Dr. Ovadia, you're a prime example of someone that's seen tens of thousands of cases of this, whether you operate on them or not. And so over the course of your entire career, we're seeing these things. And so we know that this is the protocol that should be asked. So when my patients go into their primaries, I'm like, what are the tests that I'm going to be doing? How do I do my healthcare screening? Am I insulin resistant? I think if this is a question that, and like you said, it's not going to be from the top down, it's going to come from our patients asking and prompting their doctors and the medical health professionals. I'm like, what are the questions to ask? Give us 5 questions that every patient going into their primary should be asking in order to optimize their metabolic health.
Am I insulin resistant is the one that really covers it all, right? If you want to get into the details, first of all, we can start with 5 questions. Most of them you actually don't need to ask your doctor. Ask yourself. Do I have high blood pressure? Strong indicator of insulin resistance. Is my waist circumference too high? And too high is generally defined as 40 inches for a man, 35 inches for a woman. Another strong indicator of insulin resistance. Is my blood sugar, when I am fasted, when I haven't eaten for 10 hours, 12 hours, is it too high, over 100? Again, you can go get a finger stick thing and test it at home. You can go yourself, go get a very, basic set of blood work done. You don't need your doctor's orders here in the US and in almost all states. And so you may not even need your doctor. And the final 2 questions do come back to that cholesterol panel, the lipid panel, but it does not look at the number your doctor is looking at, the LDL cholesterol. It's looking at, is my HDL cholesterol too low, meaning less than 40 if you're a man, less than 50 if you're a woman, and are my triglycerides too high, over 150? And those 5 questions tell you whether or not you have what we call the metabolic syndrome, which is another way of saying you are insulin resistant. So just start there. The scary statistic around this is 88% of the adults in the United States, as of the data that we have, which is now almost a decade old, so it's probably gotten worse, but 88% of the adults in the United States are not metabolically healthy. They can't answer no to those 5 questions, meaning that all 5 of those numbers are where we want them to be. And like I said, you don't need your doctor for this. You can pretty much figure this out yourself. And then, maybe you go to your doctor and maybe you ask them for some more advanced testing around this. But those are the basic questions that everyone needs to ask. And if anyone didn't get a chance to write those down or doesn't remember what they are, just go to my website, ifixhearts.com, right on the front page, take the quiz, totally free. It tells you what your numbers should be, and it tells you whether or not you're metabolically healthy.
That's great. And one of the things that I tell my clients is if you've had your blood sugar tested and it's in the optimal range, and you've also had your A1C tested, which is a 3-month average of your blood sugar, and that's normal or maybe borderline, then make sure you get your doctor to test your fasting insulin, because that is one of the most neglected tests that doctors, you guys can attest to this, but what I've been told by some of my clients is that their doctor literally said to them, I'm not going to test your insulin. We're just going to test your fasting blood glucose. And one doctor even refused to test a client's A1C because their fasting blood glucose was normal. So the fasting insulin for me is really important to emphasize. If you're going to go talk to your doctor for more extensive testing, that's going to be key.
Yeah, I fully agree with that. And again, unfortunately, doctors don't test it because they don't understand the power of it, what it can tell us. And again, it's just not something we were educated on testing. But very simple test. It's inexpensive. And you are right. It is one of the most informative blood markers that we can look at.
Right. And to be honest, it's not how we're trained. as a person who recently graduated from residency a couple years ago, and so I'm still relatively fresh out of the system. This is not how we are trained to understand metabolic syndrome or insulin resistance or diabetes in general. We're trained to treat it with GLP-1s, SGLT2s, insulin regimes. We're trained to how to spot it, as in looking at physical exams. But they will say do a hemoglobin H1C. They'll say do a fasting glucose. If you they'll say different tests if you're pregnant, but rarely will they say get a fructosamine or get a insulin level, that kind of thing. So it's just really the training of how doctors are trained. And so if we can change the way the doctors are trained, then it would be more of a commonplace thing to look for those other levels. When you're in training, it's so rigidly enforcing you to do it this way because we're trying to minimize patient costs by doing unnecessary tests. So it becomes as if you're not taking to the training if you do it a different way that has not been that is not commonplace to do it. And so that is why it's so hard to implement changes in residency programs in the health community at large, because when it's not across the board, then you're a little bit of a you're doing something that's weird, perverse, and you don't want to do that on the lives of your patient, because the lives of your patient should be the most important thing. And so you're essentially gambling with your patients' lives. You're doing a experiment on your patients' lives, and that's just not what you want to be considered as a doctor to be doing. So it's a tough one. It really is, Amelia.
Yeah. That's why I'm not a doctor, because I just couldn't deal with what you guys have to deal with. And that's why I have mad respect for so much more respect now doing the podcast, having you, Fumi, in my life, and getting to know doctors at the low carb conferences and symposium for metabolic health. Because, yeah, we're all in this process of rediscovery, right? And understanding that knowledge changes and evolves, and we have to do that as well as individuals, whether we're doctors, metabolic health coaches, personal trainers, to the list goes on and on. So I know that we're running short on time, and I want to wrap up. And I feel like, Dr. Ovadia, you already gave us your magical metabolic health tips, but is there anything else we'd like to close out the show with one specific personal or perhaps professional magical metabolic tip that you'd like to share with our audience?
Yeah, so really the magic metabolic tip that I always start with is eat real food. And, that's where this all begins. We need to understand the importance of what we eat and how it ends up impacting our health. And, I know there are all sorts of debates that go on out there in nutrition world and what the best approach is. But the one basic fact that, I don't think anyone, has any evidence against or can argue against is eat real food and you're going to see your health improve. So that's where I always tell people to start.
Great. Thank you so
I would
much.
say the
Yeah.
same, actually. The only thing is that I agree with 100%. I think a lot of people don't know to know. Like they can see some signs in their life, but they're not sure, am I or am I not? And so this is why I made the healthcare risk assessment on my website. That's Dokifumi. That's DOKIFUME.com. And what it is it's a quick 10 question assessment. Am I insulin resistant? Am I someone that should be getting a metabolic health practitioner? Do I need help? Are the signs and symptoms I'm seeing real, or am I imagining it? And having that definitive understanding that yes, I'm at risk, no, I'm not at risk, is really helpful to some patients. So just getting someone like to not be gaslit by your community, gaslit by your environment, and say, yes, I am insulin resistant and I need help. How do I start? That's really important. Yeah. Oh.
Well, thank you again, Dr. Ovadia, for being here. We really appreciate your time, your knowledge, your personal and professional experience that you shared with us. And I'm sure we'll see you again soon at another symposium. ifixhearts.com is your website. How about your social media?
I Fix Hearts everywhere on all the socials. And we do have something special for your audience. If you go to ifixhearts.com/magic of metabolic health, put hyphens between each of the words. If you pre-order my new book, Stay Off My Kitchen Table, you're going to get a free digital copy of my previous book, Stay Off My Operating Table.
Hey,
So for anyone
wonderful.
who wants to know where to start there, and look forward to seeing you again soon.
Wow, thank you so much. That was a
Yeah,
surprise. Oh,
big
and
surprise.
speaking of blood sugar, real quick, we also have a code for a discounted CGM, a continuous glucose monitor. Make sure you use the discount code Metabolic Magic if you go to hellolingo.com for a great opportunity to learn more about your metabolic health with a CGM for just a 2-week program. So once again, my name's Amelia, Dr. Fumi, Dr. Ovadia. Thank you so much. We are the magic of metabolic health, and thank you for being part of our village. See you next time.
Take care.
We're bringing healthy back. Them other bros don't know about the facts.